You had the lecture on the pathology of the liver already. On that magnification, what should be our diagnosis? What are the prominent features that you are able to identify? Again, number one, fibrosis. And then notice that the fibrosis in this slide is already extensive. So fibrosis should only begin at the portal areas. However, the fibrosis in this slide has already separated the lobules from each other. So normally, there should be no fibrotic tissue separating one lobule from another. So here, there is distinct separation already of the lobules from each other because of extensive fibrosis. So you have extensive fibrosis plus regenerating nodules. Both features are characteristic of what condition? Cirrhosis, okay? So in that area, you should be able to diagnose cirrhosis. However, there is another diagnosis for this slide which actually paves the way for the development of cirrhosis. Let us look for the abnormality. This is slide number 226. Sclerosing cholangitis. When we say sclerosing, what should be deposited in abnormal number? Collagen fibers. So that we should be able to see, okay, fibrosis as evident in that portion of the field. However, the diagnosis is sclerosing cholangitis, so that we should be able to see bile duct that is chronically inflamed and surrounded with fibrosis. As shown in Robbins, what is the characteristic pattern of abnormality? If you will open Robbins, how will you describe the pattern of arrangement of fibrosis? Onion skin pattern. We must look for that onion skin pattern surrounding a bile duct to come up with the diagnosis of sclerosing cholangitis. Now, unfortunately, the abnormality that we can identify here is only cirrhosis. Remember, secondary biliary cirrhosis, primary biliary cirrhosis, sclerosing cholangitis will eventually develop into cirrhosis. Will eventually develop into cirrhosis because of the obstruction of bile flow. So the obstruction of bile flow and the fibrosis that will eventually develop. So wala na tayong ma-diagnose na sclerosing cholangitis in this slide, but the end result of sclerosing cholangitis, which is cirrhosis. Again, to come up with the diagnosis of sclerosing cholangitis, we should be able to see a chronically inflamed bile duct surrounded by fibrosis. Dito wala na. At that magnification, what should be our diagnosis? Okay, let us examine the components of the liver first. Is the lobule of hepatocytes abnormal? Are the lobules of hepatocytes abnormal? How will you call the vessel pointed? Central vein. So you have a distinct central vein and then the lobules of hepatocytes. So relatively, the lobules are normal. Let us examine the portal areas. What is the abnormality that you can identify in the portal areas? Is that portal area clean looking or dirty looking? Why? Because of the presence of inflammation. We are able to see numerous leukocytic infiltrates. So that at that magnification, what should be our diagnosis? No. Yun pala ang na-identify natin na abnormality. Infiltrates of leukocytes in the portal areas. What should be the diagnosis? We haven't seen any bile duct yet. We are able to see our leukocytic infiltrates, majority of which are mononuclear. Acute or chronic? Chronic. So what is the exact name of the abnormality that we have identified? Hepatitis usually develops first in the portal areas. So this should be diagnosed as chronic hepatitis. So based on the abnormalities that we have identified. However, this slide is labeled as primary biliary cirrhosis. So again, we must look for a bile duct. What type of inflammation is seen in primary biliary cirrhosis? Ay, lumabas yung kahapon sa ano? Okay, granulomatous. Suppurative or non-suppurative? Okay, non-suppurative granulomatous inflammation. Okay, let us examine this portal area. Okay, that is a portal vein, and then how should you call that pointed structure? Portal vein, and then the corresponding portal hepatic artery. Okay? Hepatic arteriole, portal venule, and then the third component of the portal area is bile duct. So let us examine the appearance of that bile duct. What is the normal epithelium of the bile duct? Simple cuboidal. Look at the appearance of the epithelial cells. They are already distorted. So because of the presence of the leukocytic infiltrates immediately surrounding the bile duct. So the destruction of these cells will proceed in a cell-mediated fashion. Remember, granulomatous inflammation is associated with what type of hypersensitivity reaction? Type 4, which is also called cell-mediated. So those cells must be, this is a granulomatous inflammation, those cells must be okay, CD4, CD8 lymphocytes, and then the larger cells are macrophages. So the destruction of the bile ducts in this condition is because of the action of what cell? Among the three cells that we have mentioned, CD4, CD8, macrophages. CD, very good. What is the other name of that cell? Okay, so they will be releasing perforins and fast ligands, which will cause the destruction and death of the cells of epithelial cells of the bile ducts. So that should be the characteristic abnormality that you should be able to see to come up with the diagnosis of primary biliary cirrhosis. So So there is an accompanying also inflammation of the rest of the portal area. Eventually, if this condition is left untreated, it will also develop cirrhosis. Just like what we have seen in sclerosing cholangitis. So yan, bile duct surrounded by infiltrates of leukocytes. Pero mas representative yung kanina. We will advise you to record what we are discussing. Okay, if that is a liver tissue, what is your diagnosis at that magnification? Necrosis. There is extensive necrosis. Very good. However, the cause of this necrosis will be seen in the remaining dying and viable liver cells. Remaining, dying, and viable liver cells. You have actually seen this infection yesterday. Okay, so these are the remaining viable liver cells. So, para mas ma-appreciate ninyo, let us view first the appearance of the live liver cells. Okay? So, plasma membrane, cytoplasm, nucleus, and then the nucleus contains nucleolus. Normal appearance of the hepatocyte. So let us go back to the previous slide. Okay. So these are the diseased liver cells. The nuclei, what is absent in their nuclei already? Nucleolus. So that should be the appearance of the normal nucleus of the hepatocyte. Okay? So there is a clear space surrounding the nucleolus. How will you describe the appearance of the nucleolus of the cell, of the nucleus of the cell pointed? Enlarged. What else? Mayroong eosinophilic inclusions. And then aside from that, some of the infected liver cells have fused their cytoplasm already, forming multinucleated giant cells. You have seen this histology yesterday. What should be the cause of this infection? Okay, herpes simplex infection. So you should be able to see eosinophilic intranuclear inclusions plus multinucleated giant cells. Formation of the infected cells. We are seeing extensive necrosis. What should be the cause of the death of the infected cells? What is the defense of our immune system against viral infection? NK cells and CD8 lymphocytes. Okay. So, Okay, we have already discussed how CD8 lymphocytes kill virally infected cells by releasing what? Two types of chemicals. Perforins and fast ligand. Now you have already studied infections of the liver. Is there a diagnosis of aggressive hepatitis? Have you encountered that term? Mayroong chronic, mayroong acute, mayroong fulminant hepatitis, di ba? So, is there an aggressive hepatitis? Mayroon bang aggressive hepatitis o wala? Ang mga isog na hepatitis. So the abnormality that you should be able to see here will be the presence of mononuclear inflammatory infiltrates in the portal areas. Okay, so look at the appearance of the bile duct. Okay, that's the appearance of the healthy epithelial cells of the bile ducts. Unlike in primary biliary cirrhosis that we have seen a while ago, the epithelial cells are already distorted because they are being destroyed by the infiltrating white blood cells. Notice there is no extensive fibrosis surrounding the bile duct. There are few white blood cells only surrounding the bile ducts. Majority of the leukocytic infiltrates are located at the periphery of the portal area. So what type of inflammatory cells are seen? Mononuclear or polymorphonuclear? Mononuclear. So chronic inflammation of the liver is called chronic hepatitis. Please do not give the diagnosis of aggressive hepatitis. Chronic only. So chronic hepatitis, mononuclear inflammatory cell infiltrates in the portal areas. Sometimes, with increasing severity of the inflammation, the mononuclear infiltrates will slowly infiltrate inside the lobules. What should be your diagnosis for this slide? Steatosis. So, prominent is the accumulation of clear vacuoles inside the cytoplasm of the hepatocytes. However, aside from steatosis, you should be able to identify also another abnormality in this slide. So what is your diagnosis in the pointed portion? Okay, there is beginning fibrosis. Aside from fibrosis, ano? Inflammation. Very good. So remember the two main features in alcoholic liver disease. You have hepatitis and steatosis. So, hepatitis, steatosis, and then pag sige pa mag-inom na mag-inom, eventually, mayroon ng fibrosis which can eventually cause cirrhosis. Okay? So, we are seeing the spectrum of the abnormalities that will develop in chronic alcoholism. So, it will begin either as steatosis or hepatitis. So, or both, sabay yung dalawa mag-appear sa liver. And then eventually, with chronic inflammation because of persistent exposure to the toxic effects of alcohol, that abnormality will eventually develop. So, hepatitis, steatosis, and cirrhosis. All of which are the spectrum of morphologic abnormalities that will develop in chronic alcoholism or in alcoholic liver disease. Ayan, what should be your... sorry. Okay, diagnosis. Steatosis. Let us examine the portal area in plain steatosis. That is a portal area. It is clean looking without inflammation. So in alcoholic liver disease, another portal area which is clean looking. In alcoholic liver disease, steatosis is accompanied by hepatitis, and then with increasing severity of injury, fibrosis or cirrhosis eventually. So fatty metamorphosis or steatosis or fatty liver disease. First glance, what should be your diagnosis? Ano? There is bridging fibrosis, regenerative nodules. What should be your diagnosis? Extensive bridging necrosis with regenerative nodules are characteristics of cirrhosis. Actually, this slide is diagnosed as slide number 7, submassive hepatic necrosis. However, we cannot discount the prominence of the bridging fibrosis, which is characteristic of cirrhosis. So, necrosis or submassive necrosis should be seen inside the lobules. How will we be able to know that a tissue is necrotic already? What? What? Loss of nuclei or absence of nuclei. Ay, puro may nuclei ang mga cells dito, oh. What abnormality can you identify in that field? Steatosis. Okay, are those cells dead or alive? Alive. How about those cells? Alive. Okay, so what should be our diagnosis? Cirrhosis. Please do not diagnose this as necrosis because there are no necrotic cells present. You have seen this abnormality already in the prelims. What is your diagnosis? What? Okay, carbon tetrachloride poisoning. So the characteristic abnormality is the bloating of the affected hepatocytes. What is the specific effect of carbon tetrachloride? What specific organelle is affected? Carbon tetrachloride has a toxic effect to what organelle? Okay? Ano? Mitochondria. So that, why should the cells become swollen? Impairment of ATP production, and then okay, so because of the destruction of the mitochondria, what happens to ATP production? Decrease or eventually becomes cyst already. So that what will happen to the function of the sodium-potassium ATPase pump? It will become impaired. So that, do you now have an idea why those cells become swollen? Okay? So that should be characteristic appearance of the injured cells in carbon tetrachloride poisoning. Okay? Carbon tetrachloride poisoning pa rin. You have seen this slide when you were first year. We are looking at the histology of what organ? Gallbladder. Okay? Let us first identify the layers. So identify the tissue pointed. Okay, epithelium. What type of epithelium? So you have the simple columnar epithelium, and then how do you call that connective tissue? Lamina propria. Is there a submucosa in the gallbladder? Wala. Immediately the lamina propria is followed by muscularis. Okay, in that portion of the lamina propria, it is infiltrated by polymorpho or mononuclear? Mononuclear inflammatory cells. So acute or chronic? Chronic. So you should be able to see mononuclear infiltration to come up with the diagnosis of chronic inflammation. Now another prominent feature of chronic cholecystitis Another prominent feature of chronic cholecystitis is the invagination of the mucosa to the muscular layer. Those are smooth muscle bundles already. That is a bundle of smooth muscle fibers already. The mucosa has invaginated deep into the muscular layer already. What is the specific name of that sinus? Okay, Rokitansky-Ashkoff sinus. So you should be able to see Rokitansky-Ashkoff sinuses plus the mononuclear inflammatory cell infiltrates in the lamina propria. The abnormality in this slide is at that pointed area. So you have lobules of hepatocytes, lobules of hepatocyte. We should not be able to see that appearance in a normal liver. Because usually the hepatocytes abut each other. They're very close with each other. We should only be able to see small portal areas. Let us examine the components of this abnormality. Polymorphonuclear or mononuclear? Mononuclear. Now, unfortunately, this slide is labeled as liver abscess. Okay, so what cells should you expect to see in a pus or an abscess? Neutrophils. Neutrophils. So, hindi na natin ito isali. Ma-confuse kayo dito. What parasitic infection will produce abscess? Oh, bago lang nyo nakita sa parasitology yun. Entamoeba histolytica. Okay? So, normal liver tissue and then a large bile duct inside the liver. So, normal liver tissue with a large bile duct inside the liver. Now, inside that bile duct is that parasite. And those are the eggs of the parasite, the body of the parasite. Okay, the characteristic appearance of the eggs inside the uterus of that female fluke. So, that is the appearance of the liver fluke. Anyway, you will be studying liver fluke in detail when we reach the chapter in parasitology. So, normal hepatocytes, dilated bile duct containing the parasite. Dapat yan na makita. So identify the structure pointed. Identify the structure pointed. You have portal vein, hepatic artery, and bile duct. The entire thing is called portal area. Okay? Are the portal areas abnormal? There is mild inflammation in the portal areas. However, what is the prominent abnormality that you can identify? Okay, mayroong hemorrhage. So the portal areas do not have any problem. More or less normal. Walang infiltrates of leukocytes. The problem is at the central area of the lobule. Okay? So we should expect to see what blood vessel at the center of a lobule? Central vein. Okay? Maganda yan. So portal area, another portal area. So triad of portal area at the center should be the central vein. Now, at the periphery of that lobule, look at the appearance of the hepatocytes. So the hepatocytes located near the portal area, which is pointed now, and then those hepatocytes, normal or abnormal looking, are the hepatocytes? Normal. Let us go now slowly towards the central vein, area where the central vein is supposed to be. Okay. Normal hepatocytes with mild steatosis. So, and then slowly going to the central area of that lobule. What happens to the hepatocytes pointed? Okay, they are necrotic already because They do not display their nuclei anymore. What is the possible cause for this characteristic location of necrosis? This slide is diagnosed as number 126, hepatic central hemorrhagic necrosis. Anong possible cause niyan? Why are these hepatocytes still viable and these hepatocytes at the center are dead already? Where are the blood vessels located? Okay, in the portal areas. So, oxygenated blood will be delivered by the hepatic arteriole to the hepatocyte. So that those hepatocytes, if there is a decrease in the concentration of oxygen or decreased blood volume delivered by the hepatic arteriole, then more or less they can still harvest whatever oxygen is present in the blood. And then as blood flows inside the vessels pointed, which should be called sinusoids towards the central vein, eventually the little oxygen that is carried by the blood is consumed by the peripherally located hepatocytes. That is why these hepatocytes near the central vein are more vulnerable to develop or to acquire hypoxic